Hello, everyone. It was really interesting to see this challenging case, and congratulations on the result. Of course, if you may have a sapien valve there, and ideally, if you would implant it there, you're going to have a really big prosthesis mismatch because you would need to use a 20 millimeter for that case. So I'd like to present some, I'll rather be today more practical than theoretical because we have not much of time here. So I'll straight go to the Allegra product presentation first of all, just because not all of you are familiar with the device itself. So now I think every day we have different valves in our cath labs, and we like to make a decision which valve we need to use. Some of the valves shows better hemodynamic performance, some of them have better pacemaker rates, but in the end of the day, I think for a physicians to be having a predictable procedure, having the repositionable options, and maintain really good hemodynamics in small anatomies, as you can see, and also maintaining the coronary axis for these younger patients, which we are treating now, it are the key points to discuss even in heart team meetings. So having the Allegra, we know that some of you are familiar with the device itself, but it's a self-expandable valve. It's a nitrilon, and it also has the shortest frame when you compare out of the other self-expandable valves in the market. We also have this distributed radial force, starting with most of it at the beginning of the inflow, and also coming less and less to the ascending walls, also to the outflow. So the main fixation points, as you can see, are at an inflow part, which is roughly around 12 millimeters. So the other point is that the valve has a supraannular sutured leaflets. So this also gives us a better effective orifice area and less gradients in many cases. And it also can be really nicely be presented here in this bottom picture. And this is why this Allegra only has the possible treating ranges starting with a 16.5, which is like only one in the market. And this is because we have this constrained force coming in at the inflow part. And this is where, as you can see, the outflow part of the valve is even opening more, giving us more bigger effective orifice area and these patients. And this also translates into clinical practice when into the studies where Imperial 1 study was in Emperor I1 study, there was no moderate or severe prosthesis mismatches. Also, it's not a head-to-head comparison, but in many other trials, you see that this is more frequently to be seen. And also in valve, as even this case translates, which was just presented, that having a true ID of 19 and implanting an Allegra 23 without any post-dilatation, you still have a 0-digit gradients. And this is also impressive to see in this self-expandable technologies. And of course, when we are comparing with other clinical trials that shows some more of the moderate and severe prosthesis mismatch, this is where you basically think about when you have small anatomy of the valve of the patient, which would be the best valve to choose from. And also, if you compare it in really small anatomies and with the SMART trial, it also shows that there was even less moderate or severe patient prosthesis mismatches in these Allegra patients. And we know that we have many smaller anatomies in the woman, and this was an all-woman trial, which randomly compared the Allegra versus balloon expandable valve technology in anatomies, with predominantly using sapien platform as in balloon cohort. And it also showed a significant difference between lower mean pressure gradients in the Allegra group, and also moderate severe patient prosthesis mismatches were significantly lower on that side. The other key concern about the Allegra is the opening and closing force, because every time we need to think about durability, we need to think about the valve sutured points towards the commissures. and this is where having the diastole, you can see this is a so-called pole movement. The shear stresses are reduced at the commissural level, because if you are not touching the ascending aorta walls with the outflow of the valve, you still have this inward force that is forcing the diastole to become more effective and reduce any shear stress that is given to the leaflets. Of course, when you have a new valves coming into the market, you need to have anti-calcification treatment to reduce all this stress reduction as well. And of course, this is one of the valves that has a bovine pericardium. If you compare like to Evolute platform that has a porcine pericardium, and it also has some different flutter mechanisms that you will see. The other key point is that we're treating now younger patients, and we need to have re-access possibility into the coronaries and have it 12 French sizes for the cells, and also not touching the ascending aorta walls. We are able to engage all the coronary arteries in most of the cases. And when you look at the in vitro test for flow hemodynamics, we see that even on the left side, you have a really homogeneous opening of the leaflets, and the fluttering, as is seen in different valves, it's not seen there. It can also translate in durability. So overall, we also have 3 sizes of the Allegra, starting with the 23 and finishing up at 31. So you can cover the anatomy, starting with the 16.5 and going up to 27. And now it's being introduced with a new delivery system called Imperia. So this was a really game changer for the valve performance, because you are able to do the repositioning possibilities and the flexibilities even more at the catheter. So we have 18 French outer diameter valve cartridge. So this goes through the 18 French sheath. Okay, there are some centers that are doing it sheethless because it's really hydrophilic coating, and it can be done, but it's off-label, so I cannot recommend you doing that. And the other key point is just you do the opening with the one rotating knob until you feel the resistance. This is where you need to assess if you're happy about your position or not, or you want to resheath the valve. So you do it backwards and then reposition again. And if you're happy, this is where you have this safety lock mechanism. You need to unlock it and only then carry on with the counterclocks rotation to release the outflow part of the valve. Every time we have these younger patients, of course, we need to think that we need to have the commissural alignment to our patients, because it's not about only thinking about coronary access possibilities, but we also think about TAVI in the future, because this is gonna be a thing to discuss. And every time we are having a severe aortic stenosis and a patient which needs to be treated, we need to think not only about in-depth procedure, but also about maybe 10 years, 20 years in advance, and to choose the best strategy for these patients. Maybe simulate on Tremencio, which you already have like a plugins, and you can have a lot of simulations there. And of course, in terms of commissural alignment, there are like a bite mark, which you need to see in overlap view, and also the 6 gold markers that are combined in 2D view in 3. And this is where this is a shorter distance rather than the longer one should be seen on the left. So this is the main things to consider for commissural alignment. And of course, the recapturability is there. We have 3 times as per IFU to resheath the valve back to the capsule, and this can be easily done really quickly. And the other key point is also there is a partly resheathing possibility, which I will show you around. And in the end, you just need to memorize that these T-bars that you are seeing under the fluoro means that you are against the commissure, and in the end, you will see this under the fluoro. And this is what I was referring to. You need to have a bite mark in the cusp overlap view, which you see here, and all those 3, like 6 of 3, 3 of 6 actually, gold markers needs to be at this alignment, and this is also needs to be seen in ascending aorta when you introduce the valve. And if it's not, you then do some clockwise rotation to achieve that. And after the implant, you can check on that, of course, to have one in the cusp overlap view. you would see 1 T-bars on the left and 2 overlapping T-bars on the right. So, of course, there are all the enhancements that has been done to the delivery system, and this is really translated into the clinical practice. And I just wanted to share one of the videos, how it really translates into one-to-one response, because every rotation you make, it really translates to the opening of the valve and the capsule. And as you can see, once you want to reposition the valve, you come back again, and then release the valve again. And once you're happy, you just only need to unlock this safety lock and then carry on with the implant and release of the outflow part. So just a quick clinical overview, because also I think personally myself, I've done more than 160 Allegra cases, starting with the PermaFlow, so first generation device, and then what has changed into understanding the behavior of the device, and then choosing the right patients. This is the key to success to implanting the Allegra. And of course, when we know already about the product, so all the features that this product can bring, the TAVR procedure and implantation procedure, of course, needs to be planned carefully. First of all, CT scan assessment, correct sizing, not to choose borderline cases for the first cases. And of course, we need to learn from these. As you will get to introduce to Allegra, you will get to have this knowing that you might want to start with the most favorable anatomies, just to understand how the valve behaves, and then push the limits, which we are doing at everyday cases. So meaning that maybe you would use like for the 23 or 27 Allegra for smaller anatomy, because 31 valve has slightly like a different opening force, and which you need to understand while you do that. As this valve is self-expandable, of course, we need to size the valve based on the perimeter derived diameter rather than area. But of course, when you are considering the anatomy, you need to take all these things into consideration, not only the annulus, of course, the LVUT, whether the anatomy is tapered, the coronary heights, and all of that. And of course, as per now, there is only a recommendation to use Allegra valve in tricuspid aortic severe stenosis. And there are some cases that were done in bicuspid anatomy, but of course, bicuspid anatomy is not equal to another bicuspid anatomy. There are like individual challenges in these, but it's like a sub-study that is being ongoing now to evaluate the safety and clinical performance of Allegra in bicuspid anatomy. But if you're a starting center, of course, the tricuspid anatomy should be there. And to give you an answer, if it can be used in the horizontal anatomy, there is no such straight IFU recommendations. As for us now having this high volume of implants of Allegra, we know how the valve behaves, and we're really safely considering the valve even in horizontal anatomies for our patients. And of course, as overall implantation technique with the self-expandable valve, you need to use 2 views, which is usually for implantation. The first initiation of the implant, you're going to use a cusp overlap view, and then once the valve is like 80% deployed, when it touches this resistance, then you need to choose whether you need to release the valve or not. This is where we go to coplanar view, just assess the left side, and then to understand the anatomy and if the valve is covering all the sinuses equally. And of course, the other important step here to memorize that there is no unexpected tilting of this self-expandable valve, because as I mentioned in the beginning, you have the most fixation point at the inflow with 12 millimeters. And for the valve not touching the ascending aorta walls, it does not have this unexpected tilting as other self-expandable valves can have. So usually when you are releasing the outflow, you're going to have the same position without any tilting happening, which sometimes can be unpredicted. And just coming into at the end of the presentation, just to give you a native opening and the steps of the implant, which you see under the fluoroscopy. So as I mentioned at the beginning, we start to do these implantation steps at the cusp overlap view. So this is isolated non-coronary cusp. And when we go to anatomy, which we derive, of course, from the CT scan, we sometimes see that these 6 gold markers on flora are not in one line. So this is where we can do some, usually it's going to be caudal correction, and to be as much coaxial and orthogonal as possible. And then we are starting to do the opening of the valve until capsule reaches the 6 gold markers. So you aim around 3 millimeters below the LVOT. And once you have it here, you only then start to do the pacing. So like you pace 140 beats per minute for like 3 seconds or maybe 2 seconds, because the valve opening is really quickly. So I can open the valve like in 3 seconds, like from the beginning up until the end, because it's really intuitive and one-to-one response. And the same with the resheathing, of course. And ideally, you'd like to be on outer curve with the valve to be able to be as much coaxial as you can. And once you have the valve capsule opened up until there, you do some pacing for 2 seconds, and then you open the valve up until 80%. And usually this is what you see where you need to do some caudal correction, which has been done here. You do the final angio picture. You see you're covering all the sinuses perfectly, and then you only then release the inflow. You see all the 3 T-bars are disconnected. And then, of course, you bring back the nose cone to the descending aorta, close the capsule, and go all the way out. And the last picture, because I've mentioned that there are some different resheathing possibilities. So as you can see, it can be partly resheathed, which we do in most of the cases. And this is not counting toward this number 3 maximum resheathing possibilities, because you can do more of the resheathings if that would be needed. So meaning that you are coming back with the capsule up until 6 gold markers are being reached, and then the valve is slightly went back into the capsule, and this is where you slightly, if you want to push on the wire, you can do that, because the valve is not touching the anatomy at that point, and then you can redeploy the valve really quickly. Or if you're really not happy about positioning, you can also, of course, come back fully into the capsule and start over again. So this is us, part of our Center of Excellence activities that we do, and we've done maybe 12 of them already, and I'm happy to invite you in case there would be some need for that. So thank you so much for your attention.
Thank you, Dr. Briedis. This was an excellent talk. So may I ask you, can you share us some more specific information regarding the radial strength opening force of the valve, yes, especially as compared to the other self-expanding platforms? Would you advise to use it, in elliptical, let's say, and heavily calcified valves, because there is some gray zone in terms of the use of this valve in bicuspid as well? So.
Yeah, so it's a really nice question. And in terms of radial strength overall, we need to think of a better predilatation when you compare with different self-expandable anatomies valves. So ideally, you would like to take like 1.5 millimeter out of the derived diameter and choose the balloon based on that, rather than to take only the minimal axis. And this is what I've seen many of different self-expandable technologies are trying to do now more, because this is where you have less of the unfolding things happening to other valves. But then again, coming into the question in terms of oval-shaped anatomies, this is where if you have oval-shaped anatomy and you have a borderline case like 2731, this is where you need to understand if you have really long axis and short axis on minor axis. So eccentricity is really big of the valve. So this is where you need to justify maybe choosing a bigger valve to cover the maximal diameter. And in terms of post-dilatation, based on our clinical experience, if we do a really nice pre-dilatation for the native anatomies, the post-dilatation rates for us is around 5% only. And because we have really nice gradients, even in small anatomies, small surgical valves, And then we just look if there is, of course, some degree of PVL that needs a post-dilatation, we can do that. The other key point of having this really cylindrical shape of the valve helps us to choose even bigger post-dilatation balloons without risking to injure the valve leaflets of the TAVI device. So having, like, for example, like a Medtronic, you have this like a flower shape and this belly, which you cannot use more like 24 millimeter in big valves. And this is where sometimes if you have a PVL happening at the annulus contact, this is where you cannot reduce that without any risk of damaging the leaflet. So these are like different ones to discuss. Of course, the bicuspid anatomy, ZVERS 1, 0, ZVEN 0, these are different ones, but retrospectively, when I prepared for some case presentations, I've already seen that we've treated maybe 10% of ZVERS 1 with no RAFA, calcified RAFA valves, which ended up really good with a nice result. So I think this also can be done, and they're running a sub-study to assess that and maybe have a CE mark for that as well.
Good. So this is very interesting. Adoni, you have a comment?
Yes. So thank you again very much. So we have some small experience in my center with the Allegra valve system. We have seen that, especially in valve-in-valve situations, because it's a supraannular valve, you have very good hemodynamics afterwards. So this is something that we really like. What we don't really like is the percentage of pacemakers. So I know probably because of the radial strength, so the pacemaker rate is a little bit higher, but you can choose in some patients that already have a pre-existing pacemaker. We have used this in these kind of patients, and you can actually use the valve because it has very good performance. Although we are concerned about the pacemaker rate, but I think as we evolve, the valve will evolve also. I think the pacemaker rates can go down.
Yeah, so it's interestingly enough that I've heard some centers having like a higher pacemaker rates, and I don't know, because maybe this is like when you build up this experience on understanding the device behavior, our pacemaker rate is also around 5% overall. So I would not say that it's higher incidences of pacemaker, because overall we have 7% of pacemaker on all the TAVIs that we do, and we have like 5 different platforms. So I don't know. I think we aim to have a high implants, meaning around 2-3 millimeters, of course, not below, and using cusp overlap view for all the implants that we do, and this is where we try to minimize the risk of pacemakers, of course. But this is something that we should also look into. Maybe my experience in the center that we have, because I heard these kind of rates in different centers, but this does not translate into our clinical practice.
Okay, thank you, Dr. Briedis. It was excellent, your presentation and the information that you provided to us regarding this technology. So thank you, and
Thank you.
have a good weekend.
Thank you.